All right, we are going to briefly talk about the neurologic examination and neurologic disorders and sort of how the nomenclature of how we name things. So the learning objectives, this is a review back to this summer, compare and contrast incidence and prevalence. We want to define the word lesion and describe three different classifications of lesions: focal, multifocal, and diffuse. Given a case study, you should be able to identify whether the speed of onset is acute, subacute, or chronic, and differentiate between the speed of onset and pattern of progression in a neurological disorder. You should be able to state the purpose of a neurological screening exam and the comprehensive neurological exam. They're two different things. Okay, so the clinical application of learning neuroscience, this is where it really the rubber hits the road in the clinic, right? So a lesion is an area of damage or dysfunction. So a lesion can be anything and caused by a lot of different things. So the signs and symptoms following a lesion of the nervous system depend on the location of the lesion. That's why we want to, as much as possible, know the location of the lesion. And knowing the location of the lesion can help you with diagnosis. Also, knowing signs and symptoms can help you determine the location of a lesion. So it goes both ways. So depending on the distribution in the nervous system, lesions can be categorized as focal, which is limited to a single location. So an example of that would be like carpal tunnel syndrome. It's nerve compression. It's focal. It's limited to a single location. Multifocal, limited to several non-symmetric lesions. So this I picture like a car accident or a motorcycle accident where a lot of stuff happens to you, and so you have a lot of different non-symmetric lesions. Diffuse is a lesion that affects bilaterally symmetric structures but does not cross the midline as a single lesion. So that could be a brain injury or a MS. Sometimes the plaques are diffuse lesions, or it could be a metabolic issue, something like that. So understanding the effects of lesions enables the therapist to select appropriate therapy, predict therapeutic outcomes, and recognize signs and symptoms that indicate the need to refer the patient to another health professional. So a really good example of this that I've seen in the clinic, I worked in a large clinic with lots of different PTs and people with lots of different specialties. So one of the orthopedic specialty PTs was evaluating a patient after an orthopedic surgery, and they did a neurological screening, which is part of the normal orthopedic evaluation as well. And there were some incongruous results. They thought like, "Oh, this is interesting." So, what the therapist did is he discussed this with the other therapist to make sure he was seeing what he thought he was seeing, and ultimately referred the patient to a neurologist for a comprehensive neurological exam. And that was exactly the right thing to do. And it turns out he did catch something that was a pretty major neurological issue with a neurological screening exam, even though the person was in there for post-surgical orthopedic treatment. So that neurological screening exam can really help indicate the need to refer the patient to another health professional. So that's very important to help people get the care that they need. So neurological disorders can be any event that affects the nervous system, including trauma, like I said, the motorcycle accident, vascular disorders, inflammation, degenerative disorders, developmental disorders, tumors, immunologic disorders, toxic or metabolic disorders. So anything that affects the nervous system can cause a neurological disorder. And as we saw towards the end of last quarter, even some mental disorders can affect the neurological system. So the speed of onset, we are all familiar with acute, subacute, and chronic. Usually when we're talking about nervous system, acute, subacute, and chronic kind of has some additional indications, and we'll talk about them. Acute is minutes or hours to maximal signs and symptoms, and an acute onset of a neurological problem usually indicates a vascular problem. Like a stroke, you have a vascular problem. Either it's an infarction, or it's an ischemic stroke where your part of your brain's being deprived of oxygen, or it's a hemorrhagic stroke where you're losing blood, and so part of your brain is being deprived of oxygen. That's acute. Subacute is progressing to maximal signs and symptoms over a few days, and subacute onset frequently indicates an inflammatory process. So, an inflammatory process that is then compressing a nerve or affecting a nerve or causing problems in the spinal cord, that would be a subacute onset. Chronic is gradual worsening of signs and symptoms continuing for weeks or years. Chronic onset often suggests a tumor or degenerative disease. So, MS is an example of a degenerative disease that has a chronic onset. You can also have little combinations of these things. You can have a chronic disease that has acute exacerbations, where you have an acute period where there is a worsening of symptoms, and you can have relapsing and remitting. That's a common pattern with MS. So just because the particular thing you're dealing with is chronic doesn't mean it might not then become acute. So, interesting. The nervous system makes it interesting, right? So in cases of trauma, the cause is usually obvious. You got flattened by a semi-trauma. In cases of immune, toxic, or metabolic disorders, the speed of onset varies according to the specific cause. So, like I said, with stroke, it's not a trauma, but the speed of onset is usually acute. With other things, it might be subacute or chronic. The pattern of a progression of a neurological disorder can be stable, means it's not changing. So for the case of like a developmental disorder like CP, it's stable, it's not changing, but it's there the whole time. Worsening, where things are getting worse. So some of the brain injuries like subdural hematomas, they worsen over time, and we'll talk about that. Or it could be fluctuating, like I was talking with MS, where you have patterns of exacerbation and remission. Or something like fibromyalgia, where you have patterns of exacerbation and remission. The incidence is the proportion of the population that develops a new case of the disorder within a defined time period. So how many people got it this year, or developed that disorder this year? Prevalence is the current proportion of the population with the condition, including both old and new cases. So the number of people that currently have that disease at this time. The chart is from the textbook, and it shows the prevalence of some selected neurological disorders in wealthy countries. I don't know what that means, but draw your own conclusions. Per 100,000 population in 1 year. So when we look at the high numbers, migraine and chronic low back pain syndrome, those are high numbers. Fibromyalgia is a pretty high number. Brain or spinal cord tumor, it's up there. Spinal cord injury, so spinal cord injury, 13 cases per 100,000 population in a year. Interesting, but there you go. The neurological examination has two parts, the history and the testing. So the history, as you know, is a structured interview, and the speed of onset is classified at that point as acute, subacute, or chronic. And you're usually telling that by the patient's history, what they tell you about the onset. The purpose of the neurological testing in the examination is to determine the probable cause of neurological problems so that appropriate care can be provided. So in chapter 31 in the text, there are tests, and it describes the test, how it's done, what's a positive test, what's a negative test, just like anything. And so with the history, you're looking at the speed of onset, the pattern of progression. You're assessing the patient's mental status to some extent. The examination includes examining somatosensory, autonomic, motor, reflexes, cranial nerves, and gait and stance. The questions that come up from that are, is it a peripheral or central? Is it focal or diffuse? What regions are involved? Is it a syndrome? and we'll talk about what a syndrome is a little bit later. What is the probable etiology? And then you come down to the diagnosis. So the neurological screening exam is often done by the physical therapist at the initial evaluation. They might be referred to a neurologist for a comprehensive neurological exam, which involves more. So, in the course of diagnosis, these questions have to be asked. Is the lesion in the peripheral or the central nervous system? It's going to affect treatment. Are the signs symmetric on right and left sides of the body? Is the lesion focal, multifocal, or diffuse? Does the pattern of signs and symptoms indicate a syndrome? So, syndrome is where you have a group of symptoms that go together that indicate a particular cause. What region or regions of the nervous system are involved? What's the probable cause? And then what is the diagnosis? So, a lot has to be evaluated before you get to that point. And sometimes you don't have a diagnosis right away. Sometimes they might propose something. There are a lot of neurological disorders where there's not a specific test or imaging that can show that you definitively have that. And so you have to go on with what information you have. So the categories of neurological function include mental status, cranial nerves, autonomic function, motor function, somatosensory function, coordination, spinal reflexes, and gait. And there's a part of the neurological examination that includes all of those things, the comprehensive neurological examination. So all of these are examined in order to determine the best course of care for the patient.